the stars show what we're made of. Don't you look back, lift your head up, shake the dust off, tell me what you're made of. I can't hear you breathing, our lungs beating, our heart. The voice got something to say. It's a brand new day. 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 When the rain falls, when the ground shakes, when the wind blows, when your heart breaks, show me sorrow, show me laughter, show me starlight, show me what you're after. I can't hear you breathing, our lungs beating, our heart. The voice got something to say. It's a brand new day. 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 See the sunrise, oh, fire in your eyes, oh, it's about time we all saw you shine. It's a brand new day. 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 It's a brand new day.
Today's healthcare environment is going through dramatic change and is getting more and more complex. Abbott Vascular works to partner with you, giving you solutions for this complexity so you can give your patients the best possible care day to day. This can be seen with our newest drug-eluting stent, Xience Alpine, which is designed specifically for complex intervention. Abbott Vascular is committed to the PCI space. This therapy is what brought us together years ago, and it continues to evolve today with our revolutionary bioresorbable technology.
Our insights into the increasing complexity of the healthcare system exactly parallel what's happening in the cath lab. Our patients are becoming sicker, and our lesions are becoming more complex that we treat. So patients with complex lesions are no longer the exception. They're actually the majority. This is what we saw 10 years ago. And this is what we see today. With more challenging cases, we need a DES that can navigate tortuous anatomy and can also provide the best long-term outcomes. And we know that optimal outcomes are often the hardest to achieve in complex intervention. To meet this need, Abbott Vascular has developed our newest DES, Xience Alpine, specifically as a solution for complex intervention. Xience Alpine has a new high-performance catheter that gives you the technology to access complex lesions. It also brings the safety that you rely on with Xience. This safety helps you provide the highest quality of care for your patients. When we developed Xience Alpine, we worked with leaders in the CTO field to design a product for high performance in complex lesions, like calcified lesions and CTOs. Xience Alpine also brings you the confidence of an FDA indication for CTO. Everybody at Abbott Vascular, including me, is excited to bring you Xience Alpine for your complex cases. So thanks. I really look forward to the opportunity to review complex cases with you in the future.
Zions fluoropolymer. It stays to protect. The Zions fluoropolymer mechanism of protection is known as fluoropassivation. This video compares this biological mechanism in a vessel of a non-fluorinated surface to a fluoropolymer surface. Non-fluorinated surfaces include bare metal surfaces, biodegradable polymer surfaces, and even some durable polymer surfaces. These surfaces are less hydrophobic compared to fluoropolymers. Because of this, albumin, which has a hydrophobic core, is not preferentially retained on the non-fluorinated surface. Thus, more fibrinogen than albumin adheres to the surface. Fibrinogen can make this surface more thrombotic, resulting in more platelet adhesion and more platelet activation and aggregation. Fibrinogen also is converted to form insoluble fibrin. Together, these adherent and aggregated platelets and fibrin form a thrombus. This thrombus can induce leukocyte activation and recruitment, leading to an enhanced inflammatory response. This increased thrombus and inflammation can be especially pronounced to surfaces coated with certain polymer coatings that develop defects as they degrade. Leukocytes and platelets release cytokines, which promote smooth muscle cell migration and proliferation in order to wall off the strut. This, in effect, can result in excessive neointima formation. Due to this inflammation and cytokine cascade, healing may be delayed and endothelial function may be impaired. Now, let's discuss the fluoropolymer surface of Zions. Albumin has a hydrophobic core which is attracted to the highly hydrophobic Zions fluoropolymer. Albumin adsorbs to the fluoropolymer, and its hydrophobic core preferentially spreads and tightly binds to the fluoropolymer to form a protective cloak. This protective cloak prevents adherence to the more thrombogenic proteins such as fibrinogen. Albumin is not capable of activating platelets. This albumin cloaking is an essential feature of fluoropassivation, contributing to the thromboresistance of the Zions fluoropolymer. By preventing fibrinogen adhesion and platelet adhesion and activation, there is reduced leukocyte activation and recruitment, and thus a minimized inflammatory response. The benign fluoropolymer surfaces do not incite excessive smooth muscle cell migration and proliferation, but instead allow for more natural healing modulation and progression, eliciting a healing response marked by formation of a complete and functional endothelium. Altogether, this process of fluoropassivation influences both short-term and long-term outcomes. Zions fluoropolymer. It stays to protect.
Two years ago, we initiated a hospital study in partnership with St. Antonius Hospital in the Netherlands. After conducting 775 procedures, our independently verified study showed statistically significant proof that the introduction of Philips Azurion enabled St. Antonius Hospital to achieve a 12% reduction in patient preparation time, a 17% reduction in procedure time, a 28% reduction in post-procedure lab time, resulting in the ability to treat one more patient per day.
We, as a hospital, always have challenges in our budget and limited amounts of money to spend. If there are possibilities to invest in new technologies or new treatments which bring the same or better results to the patient with the same or lower costs, that's always in our interest.
We see an increasing complexity of all the procedures we perform in every normal working day. And increasing complexity means more time. It takes us more time to complete one single procedure. Another challenge we face is communication challenge. We really don't want to stop in the middle of a procedure because we have to switch to a different type of equipment.
Ik had een gezonde spanning, er moet iets gebeuren. Dat is logisch, dus ze gaan een ingreep in je lichaam doen. Ja.
When we started looking for a new interventional system, we performed an extensive baseline analysis of our workflow, and that's how we came up with Azurion.
When we acquired a new system, we were able to look at our procedures again and to see if we could gain speed by doing more patients per day or spending less time per procedure with the same or better outcomes.
We have a standardized way of setting up the system, making the system ready for every single patient that we perform. But also what we see is that our workflow actually became much smoother. And this meant that we were able to perform our procedures at quicker speed.
De duur van de behandeling die is bij alleszins meegevallen, ja. Er zit gewoon een hele rust in de hele procedure. Een heel groot stuk spanning is weg, ja. Ik had scanopnames gezien van het been. En in dat been zat dus 1 vernauwing, werd het toen geconstateerd. Maar het blijkt nu, gedurende deze behandeling, ontdekt de radioloog nog andere plekken waar de vernauwingen zaten, die hij ook allemaal behandeld heeft.
We work with the system for 2 years now. We have seen that it will certainly help us to improve.
dexterity diagnostic catheter, and the full wall technology advantage. At our core, Medtronic is committed to developing breakthrough technology that alleviates pain, restores health, and extends life. All of our market-leading guide catheters and aspiration catheters feature our proprietary full wall technology to meet today's procedural challenges. Full wall technology provides excellent torque, kink resistance, and enhanced deliverability. Now, we've applied this same market-leading technology to our dexterity diagnostic catheter, redefining catheter performance. Here's how full wall technology works. A double braid wire applied from hub to tip forms the backbone of the catheter shaft. This braid to tip design contributes to enhanced strength, excellent torque, and excellent kink resistance. The outer catheter layer material includes InSlide, a polymer additive for superior lubricity and enhanced deliverability. This material is melted through and around the braid wire to form a solid shaft construction to improve overall catheter performance. With its unique design and construction features, the dexterity diagnostic catheter therefore provides superior torque and lubricity. The dexterity catheter also features an ergonomically designed hub and a soft atraumatic tip. The dexterity catheter is designed for both femoral and radial procedures. The dexterity TRA catheter shares the same performance advantages as the dexterity catheter, but is specifically adapted for radial use. It features 5 universal curves. No new market-leading diagnostic catheter brands have been introduced by the industry in more than a decade. Every case matters to you. Every tool matters to us.
At Asiri Heart, we believe that the progression of heart disease is preventable and treatable, which is why our heart centers offer the most comprehensive range of services in private cardiac care, ranging from routine heart health screening to managing acute cardiac events. Our facilities include state-of-the-art computerized heart care centers, emergency treatment units, modern cardiac catheterization laboratories, 24-hour cardiac angiography and angioplasty, cardiac investigation centers, CT angiography with a calcium score, and cardiac consultation rooms. Our cardiac care teams work with the most esteemed cardiac specialists, and our competent critical care teams ensure the fastest recovery from even the most complicated cardiac surgery through a cardiac rehabilitation program that supports patients back to normal life in no time at all. The surgical solutions we offer include vascular surgery, surgery for arrhythmia, pediatric cardiac surgery, off-pump and on-pump coronary artery bypass surgery, minimally invasive cardiac surgery, and cardiac electrophysiology treatments. Supported by cardiac rehabilitation programs, physiotherapy, preventive cardiology, nutritional advice, counseling services, lifelong continued care clinics, and other support services. Our emergency response teams, equipped with outreach ambulance facilities, are available 24/7 on our emergency number 1313. Asiri Heart is dedicated to caring for the hearts you love, supporting all in living their highest quality life. Supporting all, live more. Asiri Heart, caring for the hearts you love.
Angina patients with a heart rate above 70 beats per minute who remain symptomatic on beta blockers represent over 40% of the angina patient population. Due to angina symptoms, they are limited in their daily activities. A high heart rate plays an important role in angina. It increases myocardial performance and oxygen demand, and decreases diastolic time, thus decreasing myocardial perfusion. This mismatch between oxygen supply and oxygen demand leads to ischemia and can provoke angina attacks. Improving myocardial perfusion is fundamental. Beta blockers, which bind to beta receptors in the heart, decrease the heart rate, decrease oxygen demand, and increase oxygen supply, thus improving myocardial perfusion. However, angina patients who still present with an elevated heart rate and remain symptomatic on the optimal dose of beta blockers require a further treatment adjustment to improve angina symptoms. Coralon is the first specific inhibitor of the IF current, located in the sinoatrial node cells of the heart. By inhibiting the IF current, Coralon reduces the heart rate. Consequently, on top of beta blockers, Coralon provides complementary benefits on myocardial perfusion, an increase in diastolic perfusion time, an improvement in coronary flow reserve in 1 week, and improved coronary collateral function. With Coralon on top of a beta blocker, patients receive an increased amount of blood at rest and during exercise, to a greater extent than with beta blockers alone. Coralon reduces angina attacks, improves physical capacity, and improves quality of life. With Coralon, get back to your life.
Best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well.
At Abbott, we're leading the way in guidewire technology. With more than 30 years of expertise, we hand-produce each guidewire with care, as if it's intended for our own family. Hundreds of Abbott team members are committed to creating and distributing guidewires to hospitals worldwide. And now, an inside look at the Abbott guidewire production process. Our California and Puerto Rico manufacturing sites house the latest production technologies, ensuring precise, consistent, and high-quality guidewires. A team of more than 45 experts spends up to 8 days hand engineering each guidewire to exact specifications and quality measures, with pride and craftsmanship at every stage. Abbott's vast organization allows its manufacturing sites to complete and package more than 30,000 guidewires per day. Whether your choice wire is stainless steel or nitinol for the support and torque you need, with high or low core support for device delivery or flexibility, or coated or uncoated for your preferred tactile feedback, we take care in optimizing our wires for your clinical needs. For more than 30 years, Abbott's deep passion for delivering high-quality guidewires makes it possible for physicians to treat patients around the world. Together, we can make patients happier and healthier.
handphone එකක් ඕනද? ගොඩක් අයින් කරපයක් ඇතිව කබඩේ හොයාගන්න බැරි ඉතින් ගන්න. ස්ටාර්ට් වීඩියෝ කියලා තින්නේ. ස්ටාර්ට් කරන්න පුළුවන් වීඩියෝ. නෑ නේ අපි වෙන්නේ මට දාගෙන ඉන්නේ. ගම් පාරිස් එකේ මහලා නේද? ස්ටාර්ට් වීඩියෝ කරලා ආයෙ කපලා දානවද එහෙම? You cannot do it because the host has
Quality of life. With Coraline,
TBHS
your life.
ඒ audience එක විතරයි නේ. එහෙනම් මට ගහන එකක් කියනවා මට. උඹට ඇහුණාද?
Heart එකක් හොඳ beat එකක් heart එකට දැන් heart එකක් දන්නවාද හදවත හරි sweet එකක් ඒ නිසාම කියලා දෙමුද art එකක් life එක ගෙවන්න ඕනේ නියම heart එකක් පුරුදු කරමු heart එකට දැන් heart එකක් දන්නවාද හදවත හරි sweet එකක් ඒ නිසාම කියලා දෙමුද art එකක් life එක ගෙවන්න ඕනේ නියම heart එකක් පුරුදු කරමු heart එකට දැන් heart එකක්
And happy life. George Stewart Health. We believe in living well.
At AstraZeneca, we push boundaries of science to deliver life-changing medicines. We have over 100 years of drug development expertise. We are committed to address unmet medical needs. Over the years, we have developed a range of cardiovascular drugs, and then came Brilinta. We have invested more than 10 years of efforts to assure high and consistent quality of Brilinta. Brilinta is one of AstraZeneca's most complex small molecules. It requires more than 20 synthetic steps to manufacture, and it is very difficult to replicate the process. The molecule has 6 chiral centers. 6 chiral centers means 64 possible stereoisomers that differ in 3-dimensional configuration of their atoms in space. Hence, having the correct stereoisomer is the key to ensure right efficacy and safety, which has been demonstrated in 679 studies with 250,000 patients, made possible only because of high purity of the right configuration. Our processes ensure reliable drugs to over 100 markets worldwide. So, never compromise of winning combination, our appropriate 3D structure, and your expertise. Brilinta is the only original ticagrelor for all your ACS patients.
දැන් මගේ වැඩ කරනවද නැද්ද?
Despite who you are, irrespective of your status, it is natural to fall ill. That will affect your daily routine. A comprehensive range of products from LifeServ will keep you alert of your medical condition. Blood pressure monitor, blood glucose monitoring system. LifeServ for a healthy tomorrow. LifeServ from Sumati Group of Companies.
You need accurate mitral valve quantification with dynamic assessment to provide quantitative information that can aid better understanding of complex pathologies. EPIC CVX Release 5.0 brings together the unique strengths of Philips and Tomtec to create a seamless, integrated experience for all your echo examinations. Designed for cardiology, built for better care. Philips EPIC CVX. Innovation and you, Philips.
Hospitals can be hectic, stressful environments. You need a monitor that can take a bounce, a bump, or a fall, especially when you're on the move. The IntelliView X3 is a rugged structure designed to withstand challenges associated with transport monitoring in hospitals. It's been tested to survive drops from up to 1 meter, so if it falls, it can absorb the impact. The state-of-the-art medical-grade display features chemically strengthened antimicrobial Corning Gorilla Glass, which is formulated so that the glass is tougher and more durable compared to competitive cover glass materials. In addition, there's a sturdy handle that not only helps you ergonomically carry it, but also protects both display and measurement connectors. The result is a robust monitor that withstands vigorous testing in our labs before it reaches your hospital. Philips IntelliView X3. Compact, reliable, rugged, durable. A monitor that will be there when you want it and your patient needs it. Innovation and you. Philips.
Health is the greatest wealth a human being can possess. A healthy mind and a healthy body makes a person truly happy. We are driven by a vision to deliver a truly caring solution to the people of this country, who deserve to benefit from the world's latest innovations and medical discoveries. As a leading healthcare provider in Sri Lanka, we stand committed to deliver only the best healthcare solutions at the most affordable prices, because we understand that every life is truly precious. We have partnered the world's most acclaimed pharmaceutical manufacturers to deliver a globally proven product. At all leading hospitals, pharmacies, and diagnostic laboratories around the country, the best healthcare solutions in the world can help Sri Lankan people live a healthy and happy life. George Stewart Health. We believe in living well.
This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
Megamax high-strength omega-3 1000 milligram pure fish oil, the newest addition to the nutritional supplement portfolio of Principal Healthcare UK, an award-winning British brand trusted by over 7,500 healthcare professionals across the globe, offering premium, high-quality products to deliver proactive healthcare and nutritional solutions to you and your family. Megamax high-strength omega-3 pure fish oil.
starting the virtual e-poster presentations. On behalf of Sri Lanka College of Cardiology, I welcome each one of you, and I congratulate each one of you for submitting your papers as e-posters and taking trouble to prepare them initially as physical posters and then as virtual e-posters. And we have lined up your posters in a certain manner, and I'm sure you have been already made aware of it. And each one of you have been allocated a time slot. So we will, I have a 3-judge panel here. All are senior consultants who are well versed with assessing publications and research, and they will be going through each of the e-posters, and they will be discussing questions during your allocated time slots. And each one of you will be allocated 5 minutes. Within that 5 minutes, you will be generally asked to present your poster for 3 minutes, followed by 2 minutes of question time. By 5 minutes, each one of you would be completing your poster presentation. And having said that, I will hand over the mic to the judges, and they will continue the poster presentation and judging procedure. And I wish all of you the very best. Thank you.
Shall we start with the first poster, a rare case of patient with uncorrected tetragephalate with pulmonary atresia surviving into adulthood, Dr. V.P. Jayasinghe.
Survived into adulthood, and then due to shortness of breath, he was referred to us from a peripheral hospital. And at presentation during the echo, we found a large and on a clinical examination, he had a holosystolic murmur which was heard all over the precordium, and he was not cyanosed, importantly, and he had mild clubbing and murmur which was heard during systole as well as diastole throughout the precordium. And our echo revealed he has a VSD overriding aorta, but we didn't find a MPA during the echo. And later on, we referred him to the pediatric cardiologist, and that he was diagnosed with tetralogy of Fallot with pulmonary atresia. And although he was slightly plethoric, he was not cyanous and did not have any cyanotic episodes as child earlier either. And which was followed by cardiac catheterization. In the cardiac catheterization, we found that his lungs were dependent on MAPPAS circulation, that is major aortopulmonary collateral arteries arising from the aorta supplying both the lungs. And then as he was into adulthood, late into adulthood, and has relatively good functional capacity, it was decided to treat him conservatively with conservative medical treatment aimed at reducing the preload. So this case is significant because tetralogy of Fallot is the commonest cause of cyanotic heart disease in cyanotic congenital heart disease. Out of the tetralogy of Fallot, actually first described in 1888 by Louis Arthur Fallot. Although Dr. Fallot described as tetralogy, it's actually a monology, where is only one defect, one congenital defect of the pulmonary infundibular tract, leading to 4 cardiac defects. Those are mainly anterior displacement of the truncal septum, a large overriding VSD, and because of the infundibular stenosis, there is right ventricular hypertrophy. However, this pulmonary atresia represents the severest form of tetralogy of Fallot, where Unless they have corrective surgery, rarely they survive into adulthood, especially without any significant impairment of activity. Our patient is significant because even though despite having this severe congenital cardiac anomaly, his clinical course was not really complicated.
Thank you. So may I know where was this cardiac catheterization was done?
Cardiac catheterization was done with the help of pediatric cardiologists at LRS.
Okay, thank you.
What was the saturation of the patient?
Saturation was on air, it was around 90, 89 to 92 vary.
Reported cases in the literature? Are there similar cases reported in the literature?
Similar cases reported in literature, but not in Sri Lanka. There was about 2-3 cases where tetralogy of Fallot had survived into adulthood without any major issues, but tetralogy of Fallot with pulmonary atresia surviving into early adulthood without any problem, I have not seen in literature except in a Persian cat. They had described a cat surviving into late adulthood with tetralogy of Fallot with pulmonary atresia.
So survival can be
had a lifespan of about 8 years.
MAPCA, no? Survival can be attributed to large MAPCA and
Yes.
in acyanotic. Huh?
Yes.
Yeah. Okay. Thanks. Thank you for presentation. Okay.
Shall we move to second presentation? Acute anterior elevated myocardial infarction complicated with the ventricular tachycardia due to diffuse coronary artery spasm. Dr. C.P. Vikramarachi.
So my patient, 64-year-old male patient with diabetes and hypertension, presented with angina pectoris to the ETU. And in the ETU, patient's conscious level suddenly deteriorated and collapsed. And we attached to the patient to cardiac monitor and found to have fast ventricular tachycardia with hemodynamic instability. So according to guidelines, we immediately given DC cardioversions to that patient. And the first ECG, you can see the ventricular tachycardia, then reverted back to the sinus rhythm. And then we show there are ST elevations, especially anterior leads as well as lateral leads, like widespread ST elevations. So as initial stabilization, we give dual antiplatelets, and ejection fraction showed around 50 to 55% with anterolateral hypokinesia. So we taken the patient to the cath lab, but like surprisingly, the initial coronary angiogram didn't show critical lesions. It shows some around 60% smooth discrete narrowing in mid left circumflex artery, as well as minor stenosis in proximal LAD, which is not as we anticipated with the given history. So then what we did, we administered 100 micrograms of intracoronary GTA, and after that we repeat cine angiogram. You can see the next cine. It shows that normalization of the coronary arteries. The patient's troponin was elevated with 12.5, and full blood count within normal limits, apart from the WBC neutrophil leukocytosis with normal CRPs. And we did investigations to check whether there are any underlying cause for this life-threatening ventricular tachycardia. But his electrolytes were within normal limits, and 24-hour Holter monitoring didn't reveal much abnormalities apart from that few right ventricular outflow tract ectopics. And we discussed with these our electrophysiologist, and we proceeded with cardiac MRI. Also didn't show a significant abnormality like scarred myocardium or any left ventricular hypertrophy or any arrhythmogenic right ventricular dysplasia for this life-threatening VT. So we attributed to this further as vasospastic myocardial infarction. So we started with calcium channel blockers, the diltiazem, and nitrates, statins, and enalaprils. So what we know about vasospastic angina, it's a functional cardiac disorder which is caused by sudden, intense, but reversible coronary artery spasms, resulting total or subtotal coronary occlusions. And these coronary spasms either can be focal or diffuse, and it can involve either single or multiple epicardial coronary arteries. But involving the multiple epicardial arteries giving the diffuse vasospastic MI is quite rare.
Thank you. Thank you. The time is gone. Now, may I ask one question from you? Have you excluded the substance abuse here?
Yes, we asked from the patient, but he didn't give any history of like any substance abuse apart from he has been consumed some alcohol, but there's no immediate like any cocaine or heroin, any substance abuse prior to this event.
Okay. At any point, have you done any EP studies to find out? I mean, I understand that you did the MRI, but the EP studies?
Yeah, we did, madam, 24 Holter monitoring, but it only showed some few right ventricular outflow tract extrasystoles. Apart from that,
other than that, any other EP studies to study the VT?
Like VT stim? No, we didn't do a VT stimulation.
Okay.
And was the intracoronary nitrates, no? Isn't it, no?
Yes.
What happened
Yes,
to ECG? What did you
Yes,
notice in the
the ECG? Actually, that first one showed around about 60% stenosis, and second one shows that almost normalization of the left circumflex and that proximal LAD, apart from minor haziness, probable minor coronary artery disease, but that significant stenosis was reversed with that.
And ECG also normalized.
ECGs was normalized. Actually, that repeat ECG normal. I couldn't show it in this picture, this particular thing. But ECGs and even that initial ejection fraction also, that hypokalemia also became normalized. So it's like very transient. Sorry.
Why did you start statin? What was the indication to start statin?
We discussed what the problem is, that the vasospasm predominantly due to hyperreactive vascular smooth muscles, but it can be probable underlying endothelial dysfunction also could attribute to this problem. So we discussed with consultant, say probable ACE inhibitor and statin has place for that underlying endothelial dysfunction. So we started both calcium channel blockers and the drugs which will correct this underlying endothelial dysfunction also. That's why start statins and endocrine. And another thing that still that LAD proximal mild haziness, we took it as a minor coronary disease because that vasospastic MI can precipitate on patient already having minor coronary disease. So with that, we started those treatments.
Will you be planning vasospastic challenge afterwards, or just to confirm that they are any place?
No, we didn't do a challenge.
Okay, thanks.
Right. Thank you
very much. So next presenter, Dr. I.S. Vikramatunga, Al-Kappa syndrome.
Good afternoon. Today I'm presenting a patient who is a 21-year-old postpartum mother who presented with shortness of breath 6 weeks after the delivery of a normal child after a normal vaginal delivery. So the diagnosis of this patient finally came as Al-Kappa syndrome, the abnormal left coronary artery origin from pulmonary artery. So this patient initially admitted with this shortness of breath for 6 weeks, and followed by 2 days history of excess angina. And on admission, we did the ECG, which showed ischemic changes with ST depressions, and the echocardiogram showed the normal LV function. And we did the troponin theta, which was repeated once, and both it showed a rising theta. Therefore, we thought of proceeding with an angiogram. So I have inserted the pictures of the both angiogram and the echocardiogram. So if you look at that, we have engaged the right coronary system with the JR catheter, and it shows retrograde filling of the left system via multiple septal collaterals. So since this is a very rare congenital abnormality, and since it presents mostly in early childhood, most of the time the diagnosis depends on the echocardiography. So this echocardiography, we could identify some few peculiar changes. So if you see the second picture, we saw abnormally dilated coronary arteries. But I would like to highlight the fact that this short axis view, it seems as if the left main is starting from the left coronary cusp, but it was not the case. And with the color Doppler, we could see the color flow jets, increasing flow jets within the septum of the myocardium. That is due to the enlarged collaterals. So as we try to, at the time of the angiogram, although we tried to engage the left system via the right femoral vein access, we couldn't do that. So therefore, we went with the CT coronary angiogram, which showed this confirmed our diagnosis. So initially, then once the diagnosis was established, we referred her to the surgery, and she is awaiting surgery. And we planned for a temporary contraception method until the surgery is done. So I'd like to highlight few facts here. So these congenital anomalies can, like this, can present in adult life as well in occasional cases. So we have to be vigilant about that. And importantly, unless we undo them, and if we just manage it as myocarditis, we had doubt that it could be a myocarditis in the beginning. So, but because of the positive troponins and there was the normal inflammatory markers without any history of suggesting myocarditis, the fever to suggest myocarditis, we went ahead with the coronary angiogram. So
okay, I think your time is up. Thank you for the presentation. We have few questions. The first one is, do you have any explanation why her troponin was high?
The troponin, the explanation would be actually she had undergone a normal vaginal delivery, so that is the time where she had the most of work to the workload to the heart. But however, probably there is during the postpartum period there may have been some.
But this is rise in theta. No, this is rise in theta, right? Yeah, so it can't be due to delivery, right?
Yes, it can't be due to delivery, but we thought there would progression of the this disease. So at one particular point, they can get some compromise of the left anterior descending artery territory flow, which would have caused some myocardial damage, so that it would have presented. The other differential diagnosis we had is whether it's an incidental finding and it's myocarditis, but finally we came that it's due to this low flow in the LAD territory, which may be due to some other coincident illness would have precipitated this.
Now, in one of your pictures, you have shown that it looks like there's a dilated left main coronary artery. Yes. So, why in the echocardiogram you look like that? What is the reason?
Because in L-Kappa syndrome, usually they get dilated coronary arteries because
it looks like it is coming to the aorta.
Yes.
In your picture, right?
Yes.
Right. So, why you look like that?
I think because this it may be this just this section, because the pulmonary artery is just next to it, so the real opening is to the posterior aspect of the pulmonary artery, which is clearly shown on the sagittal
CT
section
confirmed.
on the CT. Yeah.
CT confirmed.
CT confirmed. Yes.
Okay, right. Thank you very much for your presentation.
Thank you very much.
We are moving to next case. Case number 4 is by Dr. W.A.P.P. Jayatilaka, unfortunate case of sudden onset of hoarseness of voice.
Yeah, good afternoon. Good afternoon.
You can start. Yeah, you have 3 minutes, right? Okay.
So can you hear me?
Yeah, we can hear you. Go ahead.
Yeah, good afternoon. My patient is 60 years patient with hypertension and presented to our ETU with sudden onset hoarseness of voice and left-sided pleuritic type chest pain for 2 hours duration. And his symptoms has occurred after an argument with his family members, but he denied any other constitutional or any neurological symptoms. And on admission to the ETU, his blood pressure is low. It was around 70/40, and he has a tachycardia around 120 beats per minute. And but all his peripheral pulses were present, and there were no radial delays. And on auscultation also, he didn't have any murmurs, but he had reduced air entry in his left lower zone of the lung with some crepitations. And all other examinations were normal. Since this patient presented with sudden onset hoarseness of voice and difficulty in breathing with chest pain, we initially did the ECG, but the ECG was, there's no significant changes. And we did the urgent chest X-ray, and the chest X-ray showed the widened mediastinum with left-sided pleural affection. So we suspected the possibility of aortic dissection in this patient, and we arranged an urgent CT aortogram. And the CT aortogram came as there's a leaking aortic arch aneurysm in the descending aorta with left-sided hemothorax. And since he had hoarseness of voice, to exclude the other causes of hoarseness of voice, we did the other basic investigations, including urgent fiber optic laryngoscopy and an uncontrast CT brain and a 2D echocardiogram, but all came as normal. So this patient's on admission blood pressure was low, so we initially treated him with the normal saline bolus, and with that bolus, his blood pressure rapidly picked up to about systolic blood pressure about 180. And after that, the CT aortogram report came as there's a aortic arch aneurysm. So we took the urgent cardiothoracic opinion, and the cardiothoracic surgeon asked us to manage this patient initially medically. So to manage this patient, we started him on IV beta blockers and controlled his blood pressure. And also he had some low hemoglobin level. HB was 8, and we transfused blood as well. And after stabilization of the patient, we again referred to the cardiothoracic surgeon, and he took the patient for urgent repair of the thoracic aortic arch aneurysm. But unfortunately, the patient died during the surgery. So the important thing in this case is that this patient main presentation was the hoarseness of voice. So in the clinical history, there are some case reports that aortic arch aneurysms and aortic dissections presenting as hoarseness of voice as the initial presentation. Initially, this syndrome was known as the Ortner's syndrome, but later it was described as a cardiovocal syndrome, because the Ortner's syndrome was initially described in the MS patients, but later it was found that any structure within the aortopulmonary window can compress the left recurrent laryngeal nerve and can give rise to the hoarseness of voice. So in this patient also, we thought that the hoarseness of voice is due to the compression of the left recurrent laryngeal nerve.
Great, thank you. What was the time period from the admission to the hospital for for the surgery? What was the delay?
Surgery is done after about 1 day later.
Okay. In the echocardiogram, did you look for features for aortic aneurysm? Initial
in the
echocardiogram,
echocardiogram, we mainly look for any features of any features of aortic dissection, but there was no any features of aortic dissection.
What point you started the patient on beta blockers? Is it after the opinion from the cardiothoracic surgeon, or do you think it's the correct practice?
Oh, no. Before the cardiothoracic opinion, we started on the beta blockers.
On suspicious, you have to start, right? Okay.
So leaking aortic arch.
After CT aortogram came as.
So it's a medical emergency or surgical emergency? Both. Yeah.
This is a leaking aortic arch aneurysm, so this is surgical.
Question about delay and all that. No? Yeah.
Okay, right. Okay. Thank you very much for the presentation. So let's move into presentation number 5, an unusual finding of right side aortic arch associated with the aberrant left subclavian artery from humeral diverticulum. Dr. CPH Vithan.
Presented for an angiography following non-ST elevation myocardial infarction. And during angiography, first we attempted via right radial access, and we found it difficult. So we proceeded with right femoral access next, but found that was again equally difficult. So we know that the aorta is basically on the right side, and the branching pattern is different because usually the aorta is left-sided and the branching pattern is the brachiocephalic trunk, left common carotid artery, and left subclavian artery. In our case, all the major branches had separate origins, and we had managed to we managed to engage all the branches separately. The left common carotid artery, then right common carotid artery, then right subclavian artery, and as the last branch, aberrant left subclavian artery. And later, we arranged a CT aortogram to confirm our findings, and in my poster I have displayed those findings, and we confirmed our findings. So our patient basically had a right-sided aortic arch, which is found in about less than 1% of the population. And there are 3 variants in the right-sided. The first variant is the type 1 variant with the right-sided aortic arch with the mirror image branching pattern, and the second type is the right-sided aortic arch with the aberrant left subclavian artery, and that is what our patient had. And the third type is the right-sided aortic arch with the isolation of left subclavian artery, which is arising from the pulmonary artery. So our patient had the type 2 variant, the second most commonest type. Usually these right-sided aortic arch with different branching patterns are asymptomatic, and that was common to our patient as well with regard to the symptomatic. And but there can be associations with other cardiovascular anomalies like tricuspid atresia, tetralogy of Fallot, and transposition of great arteries. And it can cause tracheal or esophageal compression in the presence of vascular ring, but our patient didn't have any of those. Somehow, lastly, we managed to complete our angiogram. We managed to engage both left side and right side, that is with the Tiger catheter actually. And I have displayed those pictures on my poster. So I thought of sharing that knowledge with you all because in each and every year we are doing so many angiograms, and one fine day, because I learned about these anatomical variations through this patient, and one fine day we might encounter the same thing once again, though it's rare.
Yeah. So you tried the radial access first, or? Can you hear?
Yes, sir. First we started with the right radial access. Yes, sir.
Then switch out femoral.
Yeah, because initially we couldn't engage it properly, and we were we couldn't actually engagement was the issue. So for the better images, we proceeded femorally, and that was even more difficult. Then initially we tried with the Tiger catheter, and then we changed to other catheters, JR, JL, and XB3, but where we could engage both left main and right.
So you didn't do
we didn't try Amplatz at that point, sir. No.
No, pressure injection you didn't try that time. Aortogram? No. With the radial.
Sorry, sir.
With the radial access you didn't try aortogram?
No, no. That time. No, we tried. Last we got an aortogram picture and confirmed the findings. Then we demonstrated the aorta is on the right side, basically.
That's right.
Radial
okay,
access.
Okay, thank you very much for your presentation. So let's move to poster 6, broken guide wire during routine PCI to LCX, Dr. MJM Naushad.
Yeah, I'm going to report to that we did a PCI to the LCX, where it got complicated with a wire perforation. So this patient was 58-year-old. There was a lesion on the LCX to OM1 lesion, which we plan to stent from LCX to OM1. And in that one, there was we engaged with the XP3 and dilated the lesion and tried to stent it with the the LCX with after dilatation with the 2.5 balloon. And after multiple attempts, we failed to proceed, send the stent through the lesion to the OM, LCS to OM. So initially after the dilatation through the SC balloon, and we tried with NC balloon as well, and still we could not proceed with passing the stent through the lesion. So what we tried is with the second guide wire, with a Grand Slam wire, we tried to send the stent. At that time, after a while only, we noted that the Grand Slam wire tip has broken at the distal OM. So it was an experience at that time. We thought, what are the options we have at that time? So because of much difficulty, we were able to push the stent and place the stent. So we took the Grand Slam wire before stenting, and the proximal part, the distal pass, was in the distal OM. Once we stented, we noted the good flow in the distal OM, and at the moment we did not have any coronary snares. So to proceed with the snaring of the distal broken tip to snare that. So as the flow is good, as well as the distal, the broken tip is on the distal part of the OM, which is a relatively a small branch. So we decided to leave it at place, even though we had some other options to whether to we are in a dilemma to whether to stent at the distal part to crush the wire to the OM, but we did not go ahead with that. So we left the distal part of the distal part of this wire at the distal OM, and patient was asymptomatic after the procedure, and we observed the patient for about 2 days at the CCU, and so he was okay, and so we decided because there is no progression to do a check angiogram, and as we did a check angiogram after 6 weeks, and still there was good flow with the remaining of the Grand Slam tip of the Grand Slam wire in the distal OM1. So we left it alone. It's a good experience for us. So I thought we should share at this at this opportunity.
Okay, thank you. Your time is up. Now, when the wire, the broken wire end is at this time, this much of distal end of the wire, do you think any other intervention is needed? Now, let's say if you had the
that's right. We actually don't need any intervention unless we thought if there's ischemia, there can be thrombus formation, or at the there's the progressive stenosis of the vessel if it is a major vessel, and if we are concerned about those things, it's better to snare it. Or the other option we have is to put a stent on that part and crush the stent to the crush the wire to the.
Do you think that sending the snare through a stent, is it a safe option to retrieve the wire which is there in the distal most part of the branch?
Yeah, it's a difficult thing, and it might damage the struts of the stents as well. So actually, we did not proceed from there, and we stopped the procedure at that place.
I think the best option is to keep it there as it is, as you all did. And so that means anything actively was not done, isn't that so?
Yeah, we did not actively try to remove that one. And it's a learning lesson, because we were try to push the stent through, and too much of handling of the wire has caused it, and we were a little bit of in a trying to push the stent, and we have not properly handled the wire at that time.
Thank you very much
for
your presentation. Thanks. I'll go to the other one.
Shall we move into the next presentation? Can you move into the next presentation? Complex coronary intervention. The CTOs, left main, the calcified and angulated vessels.
Thank you very much for giving opportunity to discuss this topic. I hope the host can share the screen as well, if you don't mind, so that we could discuss this. All right, okay. So the purpose of this presentation is to illustrate to you how complex coronary interventions can be undertaken successfully without subjecting patients to a higher risk of MACE events in future. I have given a set of 4 difficult scenarios, each one with a particular different and difficult subset of treatment. And then the first 2 cases have been followed up for 6 years now with good outcomes. So hence the reason why I wanted to present these cases to you. The first case is of a 84-year-old diabetic lady with unstable angina, 99% unprotected left main calcific occlusion prior to the bifurcation to the LAD and the circumflex, with further 2 lesions in the LAD and the circ. Now, this lady was acute presentation, and then following initial stabilization, we discussed with the cardiothoracic surgeons, and then of course with her frailty and mobility, her calculated logistic Euroscore was, saying that there will be about 10% risk of death in that age group with comorbidities with a surgical revascularization procedure. So they did decline operating on her. So we had no choice but to fix this problem with the left main. We could not let her go home with ongoing angina. So we decided to go ahead and then rotablate this left main, calcified left main. Now the difficulties we have here, when you have a bifurcation of the left main, you cannot protect the circumflex vessel during the rotablation procedure or vice versa, because only one wire can be used for the rotablation and atherectomy procedure. What you see here is a 1.75 burr in the second poster, so the second image of the poster, going and debulking the extensive calcification in the LAD, and then we sequentially sop the wire into the circumflex and then rotablate it into the circumflex, and then we did a nice culot stent of the LAD and the circumflex and optimize the proximal vessel up to 4. Mind you, this was about 6 years ago, where IVUS was not freely available, so we did not do a IVUS in the left main at that point. But I did make sure that we did a final pot and then expanded the stents in the distal left main to about 4. Yeah. So, yes, I can hear you now. Okay. Now, what we have done here, we followed this lady up for 6 years now. She's now 89, independently mobilizing and then able to do everything normally. And then she's still alive with no hospitalization, with a single MACE event during that 6-year period. This is a diabetic with left main, calcific left main. So it's a good outcome. And then these patients have been largely excluded from clinical trials because of their advanced age. The second case is similarly of a patient who had
Can you hear me? Excuse me.
I can hear you. Can you hear me?
Right. So yeah, that's right. So we have a bit of limited time, about one.
Yes, I will rush through these three cases. The second one is of a live case demonstration at Sri Lanka Heart Association. It ended up with iotronic dissection of the right coronary artery about 6 years ago with a foreign expert there, and the patient was, unfortunately left with a dissected vessel, and then there was no solution, couldn't be discharged from hospital. So in the end, this patient, we without a help of IVUS, we managed to wire the true vessel and then check it and then stent it successfully and then get a very good result, and then she's been angina free since then. Third case illustrates issue with double vessel CTOs. Now, this patient was falsely reassured with a CT that he was not having underlying coronary disease, with dilated cardiomyopathy being the presumed diagnosis, with a EF of 28%, only 34 years old, remember. When he did the cath, we could see there were double CTOs and a 99% of the circumflex. And in the same setting, despite the risk, we managed to implant balloon pump, and with balloon pump support, revascularize both the LAD, RCA, CTOs plus the circumflex in the single setting, and he's doing very well. Fourth case is another patient who we had somebody who sternly refused to undergo surgery, CABG. You can see the amount of extensive angulation, calcification, and branch points involved in this coronary anatomy. Syntax score was very high, almost 47, but he still declined CABG. So he was given a left main culotte LAD circumflex PCI, followed by RCA, angulated RCA wiring and stenting. He's done very well for 2 years, despite the high Syntax score with no MACE events. So my message is, even in complex coronary anatomies, if you prepare the lesions well and plan your procedure, you can end up with good results. And some of the older and the younger patients who particularly have been excluded from Syntax trial in the past, we should not, decline PCI or just on the basis of high Syntax score and complex anatomies. Thank you.
Your point is well taken. Thank you very much for your presentation.
Next presentation, poster 8, dissection of the femoral and superficial dissection of the, I think, femoral artery following angiogram. Dr. M.J.M. Naushad.
Dr. Sir, again, this is regarding another patient that we did angiogram, and 55-year-old diabetic patient who had past history of non-STEMI. We did the angiogram as a routine procedure. And angiogram as at the time of the procedure, which was uncomplicated and without any pain or difficulty in procedure, went well. And patient sent for the ward. We used to do more femoral procedures and lose time, and this is done through the femoral. And while on the ward, patient has complained of some kind of a numbness in the lower limbs. And during the examination in the evening hours, and it was found to be having a low pulse and in the right femoral. So immediately we were able to do a ultrasound scan of the Doppler scan of the lower limbs and found to be having a dissection of the femoral as well as profunda arteries. And we had a discussion with the vascular team and did a urgent CT, which confirmed our diagnosis with the dissection, which is extending from the femoral to the superficial and profunda, and there was clots as well as in the profunda arteries. So it was a alarming thing that we which was some procedure which was not complicated during any, and we did not have or suspect any abnormalities during the angiogram, and still we were ended up with a dissection in the femoral arteries. There are several causes that can precipitate, like blunt needles. Sometimes we in our setup we used to have reusing of the needles. That is one cause we thought of at this scenario. And sometimes hard handling and multiple punctures, as well as when you retrieve the catheters, you can damage if you did not have the hard wires in place. And those are the common things that dissection occurs in procedures. So it was important for us to keep an eye on the patients, especially if we done a procedure. We should see the patients in the following or in the evening as well, and assess the patient to otherwise it would have been end up in a disastrous ending with the in the ischemia of the lower limb. I would like to highlight that this one, the importance of the examination of the patients in the after the procedures, even though there is no such problems during the procedure.
Yeah. Is there anything unusual in this particular scenario?
Yeah, there was unusual thing is there's little bit of extension of the this dissection, proximal as well as the distal part of the procedure. I mean, it was, and there's a immediately clot formation as well. There is in the profunda arteries. Those are the things that we thought it is unusual, because usually if it is dissection would follow the only the path of the blood flow. It was on the other way also. It has been extended. So and we were not able to detect any abnormalities during the procedure as well. Even pain or any difficulty in proceeding the angiogram was not found at that time. So
what about the bifurcation of the femoral artery? Was there any indication? Was it a high bifurcation?
Sorry, I didn't
The
get you.
bifurcation point of the femoral artery for you to tell it's unusual?
No, if it is bifurcations are a little bit upper in case. Yeah. If the bifurcation is in proximally, it can proceed. If you puncture at those places, it can happen. But
were there any issue in your case particularly?
No, we did not have any issues such as, but the puncture site as well as those things also is normal, it seems.
Okay, thanks. Huh?
Thank you very much for your presentation. We are moving to post number 9, epicardial pacing via after off-pump coronary artery bypass graft, not a mass, single center, single surgeon cross-sectional study, Dr. M.N. Lansakar.
I'm going to present epicardial pacing wires after off-pump coronary artery bypass graft, not a must, single center, single surgeon cross-sectional study. So I have no conflict of interest. So method here, the retrospective analysis of cross-sectional data collected prospective on consecutive patients undergoing off-pump CABG from 1st of January to 31st of August 2020. They were analyzed in standard predictive indicators for insertion of pacing wire, use of inserted wires, duration of use, complications of pacing wire removed, and whether patients who did not have pacing wire needed pacing. So in the pictures, the first picture shows the single monopolar pacing, epicardial pacing wire, and second one shows biphasic pacing wire. And second picture, there are different type of pacing boxes and temporary pacemakers. It shows, right? So in the background, during cardiac surgery, the heart's normal physiologic pacemaker cells can be temporarily or permanently injured and unable to maintain a normal cardiac rate and rhythm. Epicardial pacing wires are also called epicardial leads. Epicardial pacing leads are wires with electrodes at the tip that proximal end attached to the surface of the heart. It's called in the epicardium. And the distal end, the wires are drawn throughout the small puncture to the external surface to the patient's chest, and it fixed there or secured there. The wires can be connected to an artificial pacemaker to regulate the heart rate and the rhythm. And it corrects bradyarrhythmias as well. So in temporary epicardial pacing wire, insertions are routine after coronary artery bypass graft in CABG. However, no standard international guidelines being established on placement and removal of pacing wire. As placement of pacing wire associated with uncommon, but life-threatening complications are cardiac tamponade, infections, and entangled pacing wires. So this single surgeon cross-sectional study focused to identify necessity of pacing wire after off-pump CABG. Here, so the results were the total number of patients were 95, and age range between 43 to 78, and the mean age was 56 years. Here in the studies, 79 were males and 16 were female. Out of 95, 90 patients, around 94.7% did not undergo pacing wire insertion and did not require any pacing. Only 5 patients, it's 5.3%, were subjected for pacing wire insertion, where atrial fibrillation needing intra and post-op Amitron used for only 3 patients. 1 patient was episodes of bradycardia, and other patient was pre-op ejection fraction 45%. So all pacing wire were removed by day 3 post-operatively and were unused, but led to delayed discharge from the intensive care unit. And no one developed pacing wire related complications. Usually after removal of pacing wire, patient has to stay at 2 to 6 hours for post-op complications, to monitor the post-op complications. So in conclusion,
okay, I think we can see your conclusions. Can I have a few questions? So how did you decide pacing? Is it before operation or during the operation?
During operation.
So all these 5 patients are put on pacing during the operation?
During the operation, yes, please.
They develop atrial fibrillation during the operation?
Yes, during operations.
They can develop due to handling of the heart.
Because
then you had said 1 patient developed reduced ejection fraction. So is that also during the operation?
It was pre-operative.
So you take it as a risk factor, or
Yeah, it's risk factor, please.
low ejection fraction, is it? Or
No, and bradycardia.
pre-existing bradycardia, that patient.
Yes.
So you are going for a more selective approach, a limited selective approach, no? Is it, no?
So then So pre-operative identification management as in the conclusions. So it shows like that. Pre-operative identification management of current predictive indicators.
So is there any deviation from the usual practice? Off pump surgeries, the other places also they routinely put pacing wires, or
usually they put the pacing wires.
Is it guideline driven or protocol driven?
No protocol, no guidelines.
Did you analyze the number of days between the PACE patients versus non-PACE patients? You have the data?
No needed.
One of the conclusions led to delay discharge from the ICU.
That is the observation. Because when they removed, patient has to stay from 2 to 6 hours for watching post of complications.
Right, okay, thank you very much for your presentation.
Thank you very much.
The other one, please.
Okay, let's move to poster number 10, infective endocarditis in patient with cotriatrium by Dr. M.J.M. Naushad.
Again, sir, thank you very much. Again, another presentation which I found interesting during the echocardiogram, which I report a 55-year-old female patient who presented to us, who is a known patient with diagnosed patient with cotriatrium and not on a proper follow-up. And she presented to us a 10 days history of fever and with night sweats and lethargy. And she was treated at the private sector and then got admitted to the medical ward. And from there, they have transferred us for a 2D echocardiogram. And on examination, she had a low BP and tachycardia and pan-systolic murmur. And echocardiogram showed, and investigation also suggested features of infective endocarditis like high ESR and very high CRP, and WBC count also on the high side. And which are during the echocardiogram, we found that patient is having a cotriatrium, and there was a mass in the fibromuscular band, which from the where there is a from the upper chamber to the lower chamber, there is a flow from at that place. There was a infective mass which is suggestive of infective endocarditis. So cotriatrium is a very rare presentation, and 0.5 or 1% of the people who are having and they are found during the childhood. Without much of the complication, they can go into the adulthood, and major complications are the stroke because of the in those chambers there is low flow and thrombus formation, and major complication is the stroke. But in our case, we found to have a mass which is suggestive of features with the features of infective endocarditis at the opening from the upper end to the lower chamber in the fibromuscular band, not in the mitral valve. So I thought that is an interesting presentation, as well as a rare case of presentation as also cotriatrium, and thought of presenting to it. And the patient was treated with IV antibiotics and later discharged. And cultures came as negative, but because I thought the patient was treated previously from the private sector as well as in the medical ward, so cultures came as negative.
Thank you very much. I think your time is up, and we'll move into the questions. Now, in this patient, you mentioned the blood culture is negative. So after the treatment, have you remeasured the size of the vegetation, the thing that you have suspected as a vegetation? Have you seen any reduction in the size?
Yeah, madam. We did the echocardiogram after about 2 weeks, and that was the size of vegetation has slightly only reduced. Like it was 14.14 into previously, and later it was on the other side 9.8 into 16.
Yes,
And
so
because
there's
of the-
slight reduction. So in that slight, only a slight reduction.
Yeah.
And at that point, haven't you have you think of doing cardiac MRI or any other imaging or anything to exclude the possibility of cardiac tumors like myxomas? Because once again, a common site.
Yeah, because it's in the fibromuscular band, as not in the septum or the valve.
That
We did not
myxomas
suspect
can
anything.
come from any
Yeah,
place.
what are the special features for you to suspect the vegetation? Echocardiographically, were there?
It was mass attached to the fibromuscular band. Other than that, it is not actually not mobile, as well as
Sessile mass, no?
looks.
Sessile mass.
Yeah, yeah.
So the volume has also not much change, I suppose. No, there have been some the follow-up echo.
How long did you continue antibiotics?
The patient has continued antibiotic for 28 days.
28 days. So did you do echo after completion of antibiotics?
After discharge, we brought down the patients for 2 weeks after that. Still, the size of that vegetation to 40 millimeter.
Okay.
Hello.
Okay. Thank you very much. Thank you very much for your presentation. So let's move to post 11 intravenous nitrate induced aggravated steel phenomenon in a patient with multiple coronary AV fistula by Dr. C.P. Vikramarachchi.
Good afternoon. Can you hear me? Hello.
Yeah, we can hear.
Go ahead. Yeah.
Yes. Good afternoon. My patient, a 55-year-old male patient, presented with tightening central chest pain with angina, and ECG showed ST segment depressions in inferior leads with ejection fraction of 50% with inferior wall hypokinesia and with positive troponin. So initially treated as non-stem with enoxaparin, and then we performed angiogram. And while we navigate negotiate the radial tiger catheter to the radial artery, there were some radial spasms. So we administered intravenous GTN 50 micrograms, which caused like abrupt sudden blood pressure drop to around 80/50, which needed some IV ephedrine to reverse the blood pressure. So initially we were like, we couldn't think of any reason for this abrupt blood pressure drop. But after stabilizing, we engaged this left coronary artery and we performed a routine coronary angiogram, which depicted a large AV fistulas, that cameral fistulas, one arising from the proximal LAD and other one arising from the right coronary artery, which quite large from both vessels were noted. And in addition, there were another two tight lesions in distal left circumflex artery and the right coronary artery. But by that time, patient was healed and stable. We didn't stent those lesions. Instead of that, we planned ahead and we did the CT coronary angiogram, which suggests that there are cameral fistulas which drain into pulmonary artery. And then we proceeded with the adenosine administered SPECT test to find out the significance of hyperemia induced steel phenomenon due to this coronary fistula. Because most of the AV fistulas, which they are like congenital abnormalities, they don't have any significant hemodynamic instability. But this patient, since he had quite significant blood pressure drop, we performed this test and it showed there's a significant hemodynamically significant steel phenomenon after administering this adenosine. So what we have done was we planned CAPG to LAD, RC and CIRCs with clipping of the AV malformation for this patient. So that was a case because most of the time these AV connections are congenital, and the right side, the RCA is more commonly affected than the left coronary system, and the fistula more commonly drain to right sided chambers like right atrium, right ventricle and pulmonary artery, but less commonly to the left ventricle, coronary sinus, even left atrium. steal phenomenon occurs when there is reduced blood flow through these coronary arteries in like demanding situations like exertions, like this sort of vasodilatations, dehydration, which causes reduced blood supply to the coronary arteries, causes angina and myocardial infarctions. I especially showed this case because there's sudden loss of there's abrupt blood pressure drop due to intravenous GTN, and this is also could have been a cause when it happens. The steal phenomena is a cause for blood pressure drop with intravenous GTN.
Is the first presentation ischemic presentation of the patient?
Yes, clinical presentation was the ischemic presentation. Probably this is due to we are attributing to this coronary lesions also, because usually these AV malformations like quite silent in spite if become prominent if there's like any hemodynamic instability. The first presentation was the angina, sir. Yes.
Thank you very much.
Right, thank you, sir.
Let's move to post number 12, left atrial myxoma presenting with systemic embolization and posterior circulation stroke. Dr. S. Sajeev.
Today I would like to discuss a case of 49-year-old female who presented to us with the history of reduced level of consciousness for 2 days duration with left side upper limb weakness in the background of constitutional symptoms for 1 month duration. And on contrast CT was done and hemorrhages was
Excuse
excluded.
me, can you reduce the volume?
Sure.
Little bit. Okay.
Okay.
Right, go ahead. Yeah.
So CT excluded the hemorrhages, and then we did the MRI with the consultation of the neurology team. It confirmed the right side middle cerebral territory and posterior circular infarctions. And while investigating for the cause of the stroke, 2D echocardiogram was done, and it revealed a mass in the left atrium attached to the intra-atrial septum, which size is about 5 into 3 millimeters. So, and also the echo revealed the obliteration of the mitral orifice also. The Doppler revealed a surface area of 1 centimeter square in the pressure half time. Then the left atrial myxoma was diagnosed as a cause of this stroke, which has a friable surface on the 2D echocardiogram as well. And then we have done the urgent cardiothoracic referral, and they accepted the patient, and with proper preparation of the patient, they have done the surgery and removed the atrial myxoma under perioperative TOE guidance. In the perioperative TOE, we found that this 5 into 3 millimeter mass, which attached to the intra-atrial septum with a narrow stalk. So surgery was done and removed the atrial myxoma was removed, and following that, patient recovered completely except those residual dysarthria caused by this posterior circulation and the middle cerebral artery infarction. So when considering this patient has diagnosed with atrial myxoma, which is a common benign intracavitary tumors of the heart, mainly attached to the intra-atrial septum with a narrow stalk. It usually its consistency is soft, gelatinous, and friable, which can cause systemic embolization. These myxomas are commonly found in females at the it's around in the 6 decades, but the common presentations of myxoma include cardiovascular symptoms, mainly of similar to the mitral stenosis and systemic embolization and other background constitutional symptoms. So when we consider about this systemic embolization, they say more commonly in males, but in this in our case, this systemic embolization present in a female, which when according to statistics, they say it's more common in males, but here this can present in the females. So the myxomas are mainly composed of mesenchymal cells in a scattering of gelatinous extracellular matrix.
Ask few questions. Yeah. So
Yes.
you are the posterior circulation embolization. Is it rare or unusual?
Usually, it can occur when the embolization can occur through the carotid arteries and the vertebral arteries. So, usually through the large arteries, but relatively rare when considering the posterior circulation embolizations.
Now, in this patient, has she had any pulmonary hypertension with related to this large mass in left atrium?
Her TRPG was around 35, not significantly elevated.
Where she had tumor flop?
We couldn't hear the tumor flop, but we were able to hear the mid-diastolic murmur.
Okay, thank you.
Thank you very much.
Thank you.
So let's move to post number 13, left atrial myxoma with severe pulmonary hypertension in young girl by Dr. MJM Naushad. Over to you.
Thank you again, sir. This time presenting a young girl, 17-year-old girl, presenting with a history of fever and worsening of shortness of breath, which she had for about 3 months' time, and edema. And because of the murmur which was detected at the medical unit, the patient was sent for us for the echo. On examination, she had a pansystolic murmur, which is suggestive of mitral regurgitation, and as well as elevated JVP as well. So we did the echocardiogram, which showed a large LA myxoma, which is protruding through the mitral valve, which causes a mitral stenosis like pathology, as well as a grade 2 to 3 MR. And patient also had a significant pulmonary hypertension, which is about a TRPG of 90. The TRPG of 94, and RARV also dilated with features of right heart failure. So as the patient, immediately we took over the patient and referred for the cardiothoracic in the evening, and next day patient underwent the surgery to excision of this myxoma. And during the procedure, TOE, they have done the TR pressure assessment. Immediately that was gone down to about 49. And 3 days after the surgery, we took down the patient for a 2-day echocardiogram, which completely resolved pulmonary hypertension. So this was interesting patient, which we encountered with a large myxoma, progressive shortness of breath, effect like mitral stenosis, as well as the patient had mitral regurgitation with the features of right ventricular failure. So only problem in that time we thought of the cause of pulmonary hypertension. In myxomas, usually if it is left-sided myxomas, pulmonary hypertension due to the MS-like effect of the myxoma. If other causes of pulmonary hypertension in myxomas are due to interleukins, mostly interleukin 6 is the major factor that causing pulmonary hypertension, especially if it is the myxoma is on the right side. So during in the right side myxomas, chronic interleukin secretion, which is passed to the pulmonary arteries, causes a chronic pulmonary hypertension. Unlike in the left side, it's an acute pulmonary hypertension, which is due to the obstruction of the mitral valve. So you can differentiate. We could have differentiated if you did the capillary wedge pressure measurement, but we did not do because the patient was taken next day to the surgery. So most probably our patient had severe pulmonary hypertension due to the mitral stenosis like pathology. So sometimes it's important to differentiate whether it's a chronic primary pulmonary hypertension or the pulmonary hypertension is due to the mitral valve, because during the surgery it can complicate. If it is the primary pulmonary hypertension, patient have bad prognosis after the GA as well. So that I wanted to present this case because of the interesting severe pulmonary hypertension, which resolved immediately after the surgery, and I found it very interesting.
Has she had any sort of neurological problems? Because it seems to be that this one had been there for a long time for her to develop this sort of.
Fortunately, she did not have any neurological problem. Only thing she said about on and off shortness of breath, which is slowly progressing and worsening of progression, shortness of breath for about a week and with the fever. And that is the history she gave. And very fortunately, young girl, she did not have any neurological complications. with
Is there
even
any
a large.
significant left atrial dilatation? Because if this tumor has been acting as MS for it to cause this much of pulmonary hypertension, is there any significant were there significant left atrial dilatation?
Yeah, LA was dilated. I'm sorry, I could not remember the measurements, but it's dilated. LA is dilated.
We can see it also.
Yeah.
Yeah.
Thank you.
Okay,
Thank you.
Thank you very
Thanks.
much.
So let's move to post number 14. Is non-STEMI associated with the high degree of heart block by Dr. WFRD Sovis. Over to you.
Good evening. Yeah, my case is non-STEMI associated complete heart block, obviating the need for permanent pacemaker implantation weeks after percutaneous coronary intervention for saphenous venous graft occlusion. I'll give the brief introduction. Then this non-STEMI can be complicated with high degree atrioventricular blocks. It is known to be reversible in some cases of acute imperial ischemia. Permanent pacing is the routine treatment for complete heart block. But with the permanent pacing, there are a lot of complications can develop. They can include in infection, bleeding, hematoma, hemothorax, and lead dischargement, and atrial and ventricular rupture even can occur. Moreover, pacemaker lead over time are subject to fracture, insulation, break, and recall, which may require lead extraction and potentially high-risk procedure. It is therefore desirable from both social and individual of patient point of view to thoroughly rule out all reversible causes of body arrhythmia before commitment to a permanent pacemaker. I'll go to my case presentation. This patient is a 81-year-old male. He's a diagnosed diabetic hypertension and who has undergone coronary artery bypass graft 14 years back and presented to the emergency department with faintishness and lightheadedness for 2 days duration. On ETU, the ECG shows ST segment depression in imperial lead with complete heart block with rate around 30 beats per minute. And he was not on any nodal blocking agent at that moment. Then we have taken over the patient and we performed coronary angiogram with the support of the transvenous temporary pacing. There was a severe native triple vessel disease, and there was a jumping graft to the Lima and D1 that is widely patent, and there's a right radial artery graft to the OM. It is also widely patent, but SVG graft to PD, it is totally blocked in the mid with the thrombus burden. Then what we'll do without any predilatation, we directly stented that lesion with 2.530 millimeter drug-eluting stent, and we didn't post-dilatate because this is a venous graft, and we achieved the TIMI3 flow after procedure. But we expect to resolve the heart block, but there's no resolve. We waited until it disappeared gradually. After 2 weeks, keeping the inward observation with transvenous pacing. Usually in the guideline and all, usually we are only observe for the 5 to 7 days with the acute event. If there's it is not resolving, we go to the permanent pacemaker. But considering this patient, other comorbidities, age, and acute event, dual antiplatelet therapy, and following PCI, there we observe for another additional 1 week. Ultimately, end of the 2 weeks, gradually this heart block disappeared and he reverted back to the sinus rhythm. This is I am presenting this case because sometimes we can observe more than 1 week in some cases in this following acute intervention, because dual antiplatelet therapy also issue for the permanent pacing. Sometimes it will disappear in this kind of situation. In 2 weeks also it can be disappear. I have attached the images of the procedure also with this poster.
What was the TIMI flow after stenting?
Stenting, there was a distal TIMI3 flow noted. There was some clots are there, but its flow is TIMI3 flow is there.
Why do you think the patient had persistent heart block even with the TIMI3 flow?
Probably there's a following acute insult to the ischemia, insult to this nodes. It will sometimes take time to recovery. Even TIMI3 flow in some sometimes it will take time to recovery, after long time to recover, sometime rarely.
So 2 weeks sometimes can be the upper limit of the standard time that you will allow for inferior wall after correcting the ischemia to the inferior wall for the nodes to recover, isn't it?
Usually, sir, they said
is
one
too
week.
long. 1 week.
Yeah, 1 week usually, sir, we expect to recover.
Let's move to post number 15, percutaneous coronary intervention to LAD artery via brachioradial artery and anatomical variant of radial artery. Dr. S. Sanjeev, over to you.
This is another case I would like to present today. This is a patient of a 59-year-old man who came with persistent chest pain for more than 12 hours and found to have a lateral STEMI. And we took over this patient from ETU for the follow-on PCI. And we took the radial access to this patient with the six French sheath. And we did the angiogram with the Tiger catheter. And there was slight resistance noted while sending the Tiger catheter with the help of long guide. Then we did the angiogram and critical LA deletion was noted. Then we planned for a PCI at that time of angiography. So we advanced the XB3 catheter along the long guide, but we have felt a significant resistance while advancing the XB3 catheter. So we thought of a radial artery spasm, and we injected IV GTN through the sheath and the catheter, and we advanced the XB3 catheter with some resistance, but we were able to send the catheter till towards the aortic root, and we proceeded the procedure, and the stenting was done to the LAD, and we finished the stenting. And while we coming out, we were planning to do an injection and see whether there was any damage or dissection in the radial artery, because we felt resistant while advancing the XB3 catheter. So when we did the injection in the arm, we found that there's anomalous radial artery, which was the brachioradial artery. So there's a relatively narrow caliber vessel that could have caused the spasm and resistance while passing the catheter. So if you take the radial artery, usually it bifurcates at the level of cubital fossa into ulnar. Brachial artery bifurcates into ulnar radial artery at the cubital fossa level. But rarely it can bifurcates up early, usually in at the level of brachial artery or in the axillary artery. So when it bifurcates early, it causes brachioradial artery. Most commonly, this brachioradial artery commonly arises from the brachial artery, and rarely arises from the axillary artery. So here we have the case, this brachioradial artery arising from axillary artery, which comprises of only 3% of radial artery anomalies. So since we are using the radial artery access for most of the percutaneous coronary interventions, so identifying the radial artery anomalies would help in proceeding the percutaneous coronary interventions in a safe method. So because we are preferring radial access because of lesser chance of hematoma early, we can easily do the procedure, and you can early discharge the patient if we conclude only with the angiogram. So knowing the anatomy may helpful to us to proceed the intervention safely and safely. Thank you.
Right. Okay. Thank you for your presentation. Right. So let's move to the next presentation. Post number 16. It's Scimitar syndrome in older adult by Dr. W.F.R.D. Sois.
Scimitar syndrome in older adults. Scimitar syndrome is a rare congenital heart condition that encompasses an array of anatomical abnormalities, including hypoplastic right lung, right pulmonary artery with aortopulmonary collateral, and anomalous venous return from the right lung to the systemic venous system commonly through the right atrium or inferior vena cava, and sometimes dextroposition of the heart also associated in the syndrome. But this is a symptom less commonly seen in the adult, but is 3% in the 10 million of the people is a presentation in the adult population. Usually they are asymptomatic. My patient is a 47 years old, previously healthy lady, and who presented with exertional dyspnea, NYHA class 2 symptoms since 2 years, and which is progressively worsening up to NYHA class 3 symptom for last 3 month duration. and she was neither pale nor cyanosis on the admission. Cardiopulmonary examination was unremarkable, and we have done the 6-minute walk-in test also. There's no significant desaturation. But in the routine investigation, ECGs, there's no significant changes, but chest X-ray reveal there's a vessel running by the side of the right heart water to the diaphragm. This is very engorged, and therefore we have performed transthoracic echocardiography also. It shows mild right atrioventricular dilatation with preserved biventricular function without any shunts. We calculate QP-QS ratio. It was 1.41. And estimated pulmonary artery systolic pressure according to TRPG value, it was 40 millimeter mercury, slightly high. It's a mild pulmonary hypertension. Then we have performed transesophageal echocardiography. I have attached the image. It also shows this right inferior pulmonary vein directly drainage into the IVC. Other pulmonary veins were normally drained to the left atrium. We have done the cardiac catheterization, and we have given the pulmonary artery injection and waited until the venous phase, and we show the right inferior vein, pulmonary vein directly drained to the IVC, but the right superior and the left side pulmonary veins directly drained to the left atrium. And we have given the injection at the descending aorta to see the major aortopulmonary collaterals, which is also associated with this syndrome, but which was not there in our case. We have catheterization. We have taken the pulmonary artery pressure. We got mean pressure as a 30, little bit elevated. But we couldn't perform these oximetry values because at the moment oximetry is out of order in the cath lab. And then we have done the coronary angiogram. It was normal. See the pulmonary abnormalities. We have performed the computer chest tomography. Bilateral lung fields normal, but it also shows right inferior pulmonary vein directly drain into the IVC without any other abnormalities in the lung field. And this is this patient basically mildly symptomatic with mild pulmonary hypertension, and there's no shunt, also not reversal, and therefore we at the moment we are managed medically with the diuretics and blood control medications.
So you haven't found any other congenital abnormalities, no? Associated abnormalities in this patient?
Associated abnormalities we didn't found, sir. We have done the CT thorax, but lung fields are normal, no pulmonary hypoplasia, and only right inferior pulmonary vein drain into the IVC, that is called scimitar vein. This appearance is those Turkish sword appearance is swollen right inferior pulmonary vein. That's only abnormality, but we couldn't in the MAPCA also not there in the descending aortic injection.
Right. Yeah. So what made you to suspect this? Is it
because basic she came with NYH class 2 dyspnea, it worsened into NYH class 3. Then we have routinely performed ECG and chest X-ray. The chest X-ray shows this dilated vessels running from the right side of the heart border to diaphragmatic level. Then we suspect that, and we after that perform these investigations.
So I think that is a good take-home message to look at the simple investigation in evaluating a condition.
Yes, sir. Yes.
Looking at the chest X-ray,
yes,
you ultimately found this condition.
Yes, sir.
Okay, thank you very much. Okay, let's move to post number 17. Successful management of an inferior STEMI following a coronary angiogram by Dr. Mrs. CPH Vitana.
Okay, so my patient is 52 years old lady, presented for an angiogram following an un-ST elevation myocardial infarction. Her baseline ECG showed diffused ST segment depressions, and we did the 2D echo. Ejection fraction was normal. So we proceeded with the coronary angiogram, and that showed only minor plaque disease. So we recommended her for medical management. And during the last image, we noticed that there's RV, right ventricular marginal branch spasms. But following the angiogram, patient was stable in the ward, but after a while, patient had developed chest pain and had a ventricular tachycardia with hemodynamic instability. So we had to resuscitate her with intravenous amiodarone and also with DC shock. So we immediately repeated the 2D echo to exclude any pericardial effusion, but there was no pericardial effusion. And we repeated the ECG, and you can see there are ST segment elevations in the predominant in the inferior leads. And following that, patient was taken back into the cath lab for a check angiogram. So this time we proceeded the check angiogram with the right femoral axis, and we visualized the left system. The LAD and circumflex arteries both were fine, but we noticed that there's a dissection at the proximal right coronary artery. So without much delay and with no further contrast injections, we proceeded with the direct stenting of the right coronary artery from the ostium to mid vessel. Following that, the TIMI-3 flow was established, and patient was monitored for the subsequent 2 days in the ward, and that period was uneventful, and now the patient is being on our clinic follow-up. So the learning point from this case is if a patient complains of a chest pain after a coronary angiogram or a percutaneous coronary intervention, if we can't settle that with medical management, and also if patient has hemodynamic instability, it's worthwhile doing a check angiogram again. Always take her back to the cath lab and doing a check angiogram again, but just as we did, because we should keep in mind the possible diagnosis, the coronary artery occlusion leading to myocardial infarction, coronary artery spasms, and coronary artery dissection, and even it can be non-cardiac causes as well. So moving on to this iatrogenic catheter-induced coronary artery dissection, which have occurred in this patient, the reported incidence is around less than 1%, but most of the time the cases are underreported, I think. And the dissection, when we consider the dissection, it can extend antegradely or retrogradely or in both ways. In our patient, there was only antegrade dissection, and so we could intervene timely without much problem. And when we compare with the left system, RCA is more vulnerable for catheter-induced dissection because of the unfavorable anatomy, because aorta forms an acute angle with the left main coronary, but there's a straight angle between the RCA and the aorta. So that is one reason. And the other thing is RCA diameter is comparatively less than LMCA diameter, and also there's less number of type 1 collagen and smooth muscle cells in the RCA ostium histologically. So those are the causes which predisposes RCA more for RCA dissections.
Thank you. I think we'll move to questions.
So what we have to learn is we need to. Okay.
Hello. Okay. All right. Was it a difficult wiring through the dissection, or? Hello?
Not really very difficult. No, it was not that difficult, sir. We could enter the true lumen without much problem.
Did you stent up to the ostium of RCA?
Yeah, yes, sir. Because dissection was extending from proximal to mid RCA, and we were worried that it would extend to the aorta in the retrograde fashion. So to counteract that, we covered from the ostium to cover the dissected segment up to.
Okay, right. Okay, thank you very much. Okay, thanks.
Yes.
So let's move to the last post.
Thank you.
So post number 18, young adult with familial hypocholesterolemia present with acute coronary syndrome undergoing urgent coronary artery bypass by Dr. I.S. Vikramatunga.
Good afternoon, sir. Can you hear?
Yeah.
Yes.
Go ahead.
Yes. This patient, I would like to present this case importantly to show that how early in life a patient with familial hypercholesterolemia can develop its complications. So this is a case of a 19-year-old boy who was diagnosed as familial hypercholesterolemia at the age of 9 years, presented with acute coronary syndrome. So initial presentation was preceding the index presentation. He had about 6 months history of exertional shortness of breath, which is NIHA class 2, and presented with significant chest pain, suggestive of angina for 1 day duration. So the initial ECG was showing the left main pattern, that is ST elevation in the AVR lead with widespread ST depressions, and we did the troponin I theta, which was a high sensitivity reader, which was diagnostic of acute myocardial infarction. So in the examination, I have shown that this patient had multiple xanthomas all over the body, or mainly over the extensor surfaces, back of the neck, over the knees, elbows, and the face as well. So with the presentation, we did a urgent coronary angiogram. So you can see he had involvement of both left and right ostia of the coronary arteries with tight stenosis. So we, to make sure that it's not spasm, we coronary GTN also at the time of the angiogram, even after which the lesions remained same. So with this, we had to arrange urgent bypass surgery for him, following which he had an uneventful recovery. So the important facts that I have to highlight here is the management of lipids. This patient was diagnosed at the age of 9 years, and the initial cholesterol levels taken from the glucose, the total cholesterol of 794 with a LDL of 730, and he was put on atorvastatin 20 milligrams, and on admission to our hospital, still the LDL was 444. So on admission, we started him on rosuvastatin 20 milligram, and during the perioperative period, we offered him plasma exchange as well, because we don't have facilities for LDL apheresis. And in the follow-up, we added ezetimibe 10 milligram along with the lifestyle advice on lifestyle and diet modifications. However, still at 18 months, his cholesterol lipid profile is not satisfactorily reduced to a safe limit. So, and in addition, his scans of the carotid arteries and radial arteries also showed some early atherosclerotic changes. So we had, I have to highlight the fact that as this is a very young patient, we had difficulty in convincing him about the importance of strict management of lipids, and also despite adding these two drugs, as we don't have the PCSK9 inhibitors in our country at the moment, which is one of the best.
Now, after the stenting, you said the patient is on rosuvastatin 20 and estimate 10, and yes, so the LDL was 100, 275. So did you do any other treatment? Did you add any treatment, or did you continue with same dose?
No, we with the rosuvastatin 10 and estimate, that's the only escalation we did, sir.
So did you increase rosuvastatin 40?
Yeah, you have some more space.
No, in actually this patient's body weight is around 40 kilograms, and he had initial some elevation of the AST with the rosuvastatin 20. But at that time, for a short period, we could calm down the dose, and again we had to increase. And we were following up, and he didn't have any subsequent problems with that. So therefore, we didn't increase it more than that.
So what are you monitoring with the measuring tape?
Sorry, sir, I couldn't hear clearly.
Measuring tape, what are you monitoring?
So in the pictures, there's a measuring tape. What you're measuring in the?
No, no. I just wanted to show the sizes of the lesions. That's at the time of photography, the photographer has placed the tape. That's why.
Okay. Okay. Thank you very much. Thanks.
Okay, thank you very much.
Right. Okay. Thank you very much for that those excellent presentations, poster presentations. So we'll be judging your posters, and the results will be announced at the end of the session, and then you can know the results by virtually. So please connect to the main session. So we'll announce at the end of the session. Thank you very much.